So what we're going to do today, and it's going to take the 2 hours now and this afternoon, is we're going to cover normal calcium homeostasis, we're going to cover hypercalcemia, and we're going to cover hypocalcemia. So this is kind of like an introduction into this whole field. And I like to start very simply because you can look at this as a very simple system. This is a system that has compartments. It has the intravascular compartment that we access all the time by drawing blood. And calcium is, of course, the key element in this intravascular compartment. Of course, we're aware of phosphate and albumin and hormones that circulate. But there are three organ systems that work together to keep our serum calcium really amazingly stable, And these are the three organ systems, the GI tract, the kidney, and bone. And they work together, they work separately, and one of the prime drives of these organ systems is to keep the serum calcium normal. I know there are many other reasons, but that is an important function of these organ systems. And they do so by a very exuberant dynamic. And it is sort of schematically shown here. That intravascular compartment keeps the serum calcium between a narrow normal limit. It doesn't matter, 8.2 to 10. This case, it was 8.5 to 10.5. But most laboratories give it about a 2 milligram per deciliter excursion range in the normal range. And then, of course, the extracellular compartment is a much smaller amount than there is in bone, which is the major reservoir of calcium. Much more, 99% of calcium is in the skeletal compartment, and only a tiny biopsy, if you will, of that calcium, overall calcium amount is in the circulation. In order for the serum calcium to be regulated within such narrow normal limits, these systems are helping. The GI tract will bring in a certain amount of calcium per day, and the 500 to 1,000 milligrams is probably an average amount of typical people in this country. The absorption will be anywhere from 350 milligrams to 700, depending upon your needs. Remember, there's a secretory component. There is calcium secreted into the GI tract, as well as absorbed. So then in this particular cartoon, the net absorption of calcium is about 150 to 300 milligrams. And you'll notice that that small amount that's net absorbed is exactly the same small amount that the kidney gets rid of. So the typical 24-hour urine calcium will be somewhere between 150 and 300 milligrams per day. So that matches the amount of calcium that we've absorbed. So in that regard, we are in balance. I don't know if Tom Nicholas told you yesterday that the kidney is the smartest organ in the body. He thinks so because he's a nephrologist. But it's a very smart organ. Look at how much calcium is filtered per day. 7,000 to 10,000 milligrams of calcium is filtered at the glomerulus per day. And only 150 to 300 is lost. So 99+% of filtered calcium is conserved by tubular mechanisms. And that requires a very smart organ to do that job. That is reclaiming a tremendous amount of calcium that we filter every day. Okay? So the GI tract and the kidneys, if things are working well, are balancing each other. The skeleton, shown here, is also a very dynamic organ. Those of us who are endocrinologists appreciate the fact that the skeleton is just as active as any other organ. The liver, the kidney, the heart, the brain. It's just not a static scaffolding that keeps us upright. And as you know, there's a lot of activity every day, that there's bone being resorbed and there's bone being, calcium being formed, accrued. So this dynamic of calcium accretion and calcium loss is somewhere between 300 and 500 milligrams per day. So that is how much? That's about a good glass of milk worth of calcium that we're turning over, but we're turning over in such a way that we're balanced. The amount of calcium that we lose is balanced by the amount of calcium that we put into our skeleton. That is true in people who are in steady state. And I would say all of you, except for me, and Noel, you're probably included in this, are probably in steady state right now. You're not gaining and you're not losing. But this isn't going to last forever. In fact, it's going to last not for many more years. And then you're going to be more in my dynamic. And my dynamic is the aging dynamic, where this is not really balanced. There's a little bit more calcium lost per day than calcium accrued. Very small, 30 milligrams worth of an imbalance. But every day, that begins to add up. And that is one of the features of age-related bone loss. Now, if you all were 10 years younger, maybe 15 years younger in some cases, this wouldn't be true for you either, because you would be growing and you would be forming bone. So you would be putting more calcium into your skeleton than you would be losing. And the growing skeleton in the adult human is a modeling skeleton, not a remodeling skeleton. And we're going to go into this distinction between modeling and remodeling. But in the adult, this turnover is remodeling. Bone is being metabolized, calcium is being resorbed, and the little divot, that bone remodeling unit, is being filled by calcium. And that 3 to 5 month bone remodeling period is what keeps our bones generally healthy and resilient and not overly mature. So this is it. The typical dynamic, 500 milligrams per day turnover, the same amount going into bone, the same amount lost from bone into the extracellular and intravascular space, and that's worth about 2 glasses worth of milk or the equivalent. So these 3 organ systems need help. They need signals. And we are the signaling specialty of medicine. Endocrinology is signaling. We endocrinologists know about these hormones that signal this, signal that. And if it weren't for the endocrine system, we wouldn't be human beings. Organ systems cannot function without signals. And we can't function as people without signals. And so these are the 2 major signals. And they're both hormones. Although one we still call a vitamin, right? We still call it a vitamin. But it's a hormone. We'll talk about that. But obviously, parathyroid hormone is one of the key regulators. And this is the molecule itself. It has 84 amino acids. In the yellow is the portion of the full-length peptide that has full biological activity. That is, full classical biological activity. Historically, how did we get to know that PTH1 to 34, which is known as teriparatide, I'm not speaking about a drug, I'm talking about the portion of the molecule. How do we know that PTH1 to 34 has all the requisite classical biological activities of the full-length peptide? This goes back to the Auerbach days when I started with Jerry. He and John Potts in 1969 had deduced the sequence of this molecule. They had isolated it, and there was a big breakthrough in terms of how they isolated it from bovine parathyroid glands by homogenizing these bovine glands in hot acetic acid. And it was Auerbach's great insight that got rid of all tissue, but did not destroy parathyroid hormone because it's very stable in acid. And that led to the isolation of PTH1-84. And then what they did was to look at the various lengths of the amino with terminal end of the peptide. And they did it by certain kinds of sequencing. And they got to this molecule, and when they realized, when they knocked one of these amino acids off, like PTH1-33, they lost almost all the biological activity. And when they took the amino end, the serine at the amino terminal end, when they lopped that off, they lost all the biological activity. And so they came up with this idea that PTH1-34 was the molecule that mimicked the full-length peptide. That is true, although we're not so sure that there aren't other functions of the so-called mid-molecule or C-terminal portions of the molecule. If those of you who like to ask the question, why is this molecule made as a full-length 84 amino acid peptide when we only need a 34 amino acid peptide? The body is not dumb. It doesn't make an 84 amino acid molecule when it can do just as well with a 34, right? It's got to be something that is useful for the parathyroid glands to secrete this molecule and not the smaller one. And I don't have an answer for that. We still don't know. But this 1-84 molecule is secreted, and it rather immediately goes to its receptors, the PTH1, also we call it the PTHRP, we call it the PTH1/PTHRP receptor, a single receptor. There is another receptor in the brain, but we won't talk about that. And this molecule goes to its receptor sites, but it doesn't survive very long. It is rapidly metabolized by circulating proteases. And you know about this because after parathyroid surgery, we do intraoperative monitoring of PTH. And after the parathyroid adenoma is taken out, I should say out, I should say right out. I almost said it like you say it. The parathyroid hormone, which is measured after the gland is taken out, baseline, taken out 2 minutes, 5 minutes, 10 minutes later. And if the parathyroid adenoma is the only abnormal parathyroid tissue, that baseline parathyroid hormone level will fall by over 50% into the normal range. So in 10 minutes, this hormone's gone. So it has a very short half-life. And there are many other examples of that. But this molecule does not last very long in the circulation. And its half-life is in order of minutes. OK. We'll talk about PTH1-84 later in more detail. And we don't know. But by the way, Tim Murray, this is the Canada Day, I guess. Tim Murray is from the University of Toronto, and he's now retired. But Tim, for most of his career, was trying to figure out what was going on with this part of the molecule. Was there another receptor? Could that have some biological activity on its own? But we still don't know whether or not there is something there. OK, so circulating plasma calcium comes in 3 flavors. About half is bound to albumin. About half circulates as iodized or free calcium. And a very small amount, 5 to 10%, circulates in a complex, like citrate, sulfate, phosphate. When we measure the serum calcium, we're measuring everything. We're measuring total calcium. And only if you go to the trouble of measuring ionized calcium will you know what ionized calcium is. You need to do a correction to get a sense of what the ionized calcium is. And obviously the ionized calcium is the physiologically active form of calcium. And the way we correct for calcium if there is an abnormality in albumin is by a simple formula. For every gram per deciliter, the albumin is lower than 4 grams per deciliter. You have to up-titrate the measured serum calcium by 0.8 milligrams per deciliter. So in patients in the hospital who are sick and lots of other things going on, I have a patient in the hospital now with she has hypopara. It's a complicated patient, but she has some draining, she has a malignancy that drains a lot of proteinaceous fluid in her pleural space, and her serum albumin is 1.5. And her calcium is 7.5. Well, that sounds pretty bad, but if you correct her albumin, you'll find that her corrected calcium is actually quite normal. So if the serum calcium, the albumin is 3, and the serum calcium happens to be 8, you're going to adjust upwards that value of 8 to 8.8. If you're down by 2 grams per deciliter, you'll uptitrate by 1.6 milligrams per deciliter. So that's what you'll do if you measure total calcium. So let me ask you, how many of you rely on the total calcium measurement versus the ionized calcium? So how many, let me put it this way, because the question is better asked. How many of you use ionized calcium? 1, 2, 3. Only 3 of you. The rest of you do, you too?
Not always.
No, sometimes. Okay. Depending on some specific need. But generally you use total? Okay. NIH, where's my NIH? Your NIH. I know you do ionized calcium. And that's because Steve Marks, who is now retired, I think he's retired now, but the NIH group has always believed in ionized calcium. And they thought that we extramural people aren't getting it because the ionized calcium is what to do. You measure ionized calcium too?
We do, but our bone person is actually from the NIH. So.
Ah, so that's it. Yeah. This is the ionized calcium mafia in your neck of the woods. So why do you measure ionized and I don't? What's the difference? The difference is, well, tell me, why do you measure ionized calcium?
So I have learned from Dr. Collins' group that it's more accurate than the total calcium because most of our patients are very sick. Most of them have like neoplasia. We get called for a consult, or they have a lot of variations in volume that will affect directly or indirectly the albumin levels as well. Number 2, because we don't pay for it. So
very important.
That's another reason, but we believe it's more accurate than the total calcium.
Okay, okay, I accept everything you said. So why is it that I don't use the calcium? After what you said, I'm sort of an odd person out. So the reason why you measure ionized calcium and you believe in it, and you're right, you're getting a good measurement, is because you know what you're doing. You have a control of the system, and you know about the ionized calcium machine. It's always on. It's always calibrated. You know how to draw the blood anaerobically. You know how to get the sample from the bedside to the lab. The technician that draws up the sample anaerobically, doesn't let that sample see air because you change the pH. Once you change the pH, you're going to change the partition between ionized and total. So that's fine. But what big hospital, big medical center can do that? I don't trust this hospital to be able to do it. But in pediatrics here, they do have their own machine in pediatrics. They do micro volumes, and they do ionized calcium. And many pediatric groups do ionized calcium. But most of us in adult medicine, with few exceptions like NIH, will go for total, and we'll make the adjustment. We'll adjust the, and that's pretty good. Not perfect, but it's pretty good. And it's better than an ionized calcium done when you don't know how to measure ionized calcium. Okay? Now, here's a question for you. Suppose the albumin is 5 grams per deciliter. And we're saying that the we want to normalize the low albumin to 4. Somebody comes in with an albumin of 5. Do you titrate down? Is that stoichiometry still valid? The calcium of whatever it is, 8, the albumin's 5, is that really a calcium of 7.2? Have you played with this? Have you done that? Well, nobody has actually done a study to know whether what I'm going to tell you is true or not. But I don't think it's true. I don't think the stoichiometry works the way we are talking about the low albumin. And so what I do is I don't do anything. If the albumin is over 4, I take the total calcium for what it is. And I've never been able to convince myself that a higher albumin is altering that stoichiometry. I may be wrong, but nobody's done a study, to my knowledge, to address that point. Okay. So I mentioned the ionized calcium, and this is why you measure it, because the ionized calcium rules the roost. It is the ionic form that is physiologically active, and it also is the form of calcium that regulates parathyroid hormone. There are 2 major regulators of parathyroid hormone, and one of them is the circulating ionized calcium. And again, the notion is that the serum calcium wants to be normal all the time and doesn't want to vary very much all the time. So what's normal? Well, normal, by the way, this paper is a little old, 1931, not exactly current literature. These guys were thinking about this almost 100 years ago. So how do you determine what's normal? What you do is you take a random sampling of so-called normal people and you measure something, calcium. And you measure 200 people. The next 200 people who come off the street and get their calcium measured, they will have a mean and they'll have a standard deviation. If you want to be 95%, you want to capture 95% of the normal population, it'll be the mean and plus or minus 2 standard deviations. If you want to capture 99% of the population, you'll have 3 standard deviations. But most labs will go for 2 standard deviations. And that's it. So this is the normal calcium range, 8.4 to 10.2, let's say, about 2 milligrams per deciliter. Now the question is, that's the normal population range. But what is your population range? Do you think, Carmen, you moved from 8.4 to 10.2 from day to day? If you were to measure your calcium every day for the next week, would you range some days, you'd be 8.4, and other days you'd be 10.2? This is in your normal state. Nothing has happened to you. You haven't become dehydrated. What would you say, yes or no?
That seems like a big variation. But
Yeah, it is a big variation. You're right. I don't think you'd be happy. I don't think you'd be happy if you moved from 8.4 to 10.2. And in fact, you don't. You don't. You don't want your calcium to move very much. Now, I don't know whether this is what you like to be at. Is that your happy zone? I have no idea. Maybe your happy zone is here. But the point is that for any regulator, any analyte, the body's own regulatory system is much more precise than the population range. Okay? This is sort of an important concept that it will speak to parathyroid disease. But let's go back to the calcium. So this is what you're doing. We're all doing this over 24 hours. Yeah, there are a little bit of excursions up and down. If you drink a glass of milk or some calcium supplement, your calcium's going to go up a little bit. But you're not going to be able to measure it going up a little bit because the measurement isn't that precise and accurate. But it will go up a little bit. So when you eat and there's calcium in your food, it'll go up a little bit. When you're fasting, it'll go down a little bit, up and down. And in fact, Robert Haney from Creighton University, who passed away just a few years ago, Bob Haney was one of the great bone people, one of the great nutritional scientists in our country, did a study to look at this control. And he took 24 healthy postmenopausal women, and he gave them a single 500 milligram tablet of calcium from 3 different supplemental preparations. And what he showed was against a placebo group that didn't get any supplemental calcium. But these 3 other groups that got 500 milligrams of 3 different calcium preparations, he showed that as early as you could measure the parathyroid hormone, it was down, suggesting that the change in calcium, as minimal as it was, and I'll show you how minimal it was having a huge effect on the circulating parathyroid hormone, which would mean affecting the secretion of PTH. And on the left is shown the excursion of the calcium in these 3 groups. So it went from 9.7 to 10.2. So it went up by 0.5 milligrams per deciliter. And that was associated with this big drop in PTH. Now that looks like a big change. But if you really look at it as a percent change, it was like 1 to 2% increase in the serum calcium was associated with a 40% drop in the serum PTH. So again, almost an imperceptible modulation of the calcium, minute to minute, second to second, will have rather instant effects on the secretory function of the parathyroid glands. So about, how many years ago? 1973. That's a long time ago. 45 years ago. I was leaving NIH, and Ed Brown, who had trained at the Brigham, every year there was another one of us. And for 20 years of Dr. Auerbach's tenure at NIH, he trained one of us. And he sort of populated the country with people like me. And one of these people is Ed Brown. And Ed Brown comes to Auerbach, and he says, this exquisite control of calcium, there's got to be some system that recognizes the ion. Like a hormone has a receptor, I think calcium must have a receptor. And that was a bold, almost heretical idea that an ion could have a receptor. So Ed went ahead, and for the next 5 years, and then in 1983, this receptor was cloned. This is the calcium sensing receptor. And indeed, for sure, there is a signaling system that recognizes ionic calcium. And this is the molecular form of it. It's a G protein linked receptor. The extracellular domain is shown at the top, and the intracellular domain here. And it literally transmits the ionic signal. Type 1 ligand would be a divalent cation. Most potent is calcium, but magnesium can signal, manganese can signal, but calcium is primarily the activating ligand or the inactivating ligand. And then there are these type 2 allosteric inhibitors like cinacalcet and the calciolytics that bind somewhere with the G protein and modulate the system, but they don't bind at the ligand binding site. So if you schematically, if the blood calcium goes up, the system is going to be occupied. Those calcium receptor sites are going to be occupied. And calcium intracellularly is going to be transported by virtue of the binding from the system, as well as a passive influx of calcium that actually doesn't always use the receptor system. But this interaction leads to an increase in intracellular calcium, and that, of course, leads to a reduction in the synthesis and secretion of parathyroid hormone. On the other hand, if the system goes the other way, there's going to be a reduction in the intracellular calcium, and there will be an increase in PTH. So either way, in a normal person, calcium goes up a little bit, PTH goes down, and on the other hand, if the calcium goes down a little bit, PTH goes up. I don't know if you've observed this in your patients with hyperparathyroidism. In hyperparathyroidism, the controls are not as exquisite. Obviously, the homeostasis is out of whack. This adenoma is setting the system higher, and it takes a higher calcium to control this system. But it's under control, because if it wasn't under control, the calcium would go up to 100, and you'd be dead. So it's a different set point in hyperpara. But if you look at your patients, and I just saw one just the other day, calcium tends to be whatever it is, let's say 10.8, and the PTH is whatever it is, 100. And then the calcium will go up on one occasion, it goes up to 11, and the PTH is 80. Or on another occasion, the calcium is 10.6, a little bit lower, and the PTH is 110. Even within an abnormal milieu, this very exquisite control, this seesaw relationship, can be demonstrated, and it's a function of the system and how it responds so quickly, even in a condition like primary hyperparathyroidism. So again, a schematic. This is the parathyroid cell. The extracellular calcium is shown here. The calcium receptor is there. And if there were any reason for the calcium, extracellular calcium, to drop, the signal gets activated, and you have an immediate secretion of parathyroid hormone. Or if you used an antagonist, like a calciolytic, you would mimic the same thing, preventing calcium to interact with the receptor, and you would have immediate secretion of parathyroid hormone. So there are, soon after the calcium receptor was identified, a number of diseases seem to fit an issue with the calcium receptor. If you activate the receptor, and there are activation mutations of that calcium receptor, you have an autosomal dominant hypoparathyroidism. Inactivation of the receptor would lead to an increase, a chronic increase, and you'd have a form of hyperparathyroidism. The activation of the system leads to, again, the mutations itself in the receptor. There have been a few antibodies, humans that have developed antibodies activating the receptor, and they have hypocalcemia. And then the calcium mimetic agent, cinacalcet, is that allosteric inhibitor, activator, mimicking calcium and sending the signal to the parathyroid cell to shut everything down. So the activation systems are shown here. And the activating mutations, if you look at that relationship between calcium and the parathyroid hormone response, this is the normal relationship. And in these situations where you have enhanced sensitivity to the receptor, the curve is shifted to the left, and the extent to which the curve is shifted to the left will depend on the mutation. And some of them give you a greater shift, some of them don't. But they all will shut down the system when the calcium is low. That's why in autosomal dominant hypoparathyroidism, you have a calcium of 6, and you have a PTH that may be 20 or so. And that's not normal. But the system thinks it's normal because of this change in the relationship between calcium and PTH. So inactivation of the calcium receptor, there are inactivating mutations. there are inactivating antibodies, and the calciolytics, again, they're the opposite of the calcium mimetics. We don't have any calciolytics available. There have been a number that have been developed, but they haven't yet shown themselves to be useful. But the calciolytics will also act like an agent to increase PTH. And you can imagine, therapeutically, there might be many situations where you would like a calciolytic. So again, the human disorders, the hypercalcemias are the inactivating mutations, and the heterozygote condition is the familial hypocalciuric hypercalcemia. How many of you have seen FHH? NIH can't answer. How many? Any of you besides? You've seen one? You've seen two? One, two? Yeah. So NIH sees a lot, and that's because you have an interest in FHH. And you have a big referral population. But those of us who don't live at the NIH rarely see FHH, rarely see FHH. It actually is a very rare disease. And even in people who have a calcium, 10.8, a parathyroid hormone level of 100, and a urinary calcium excretion of 80 or 70, and even with a calcium clearance to creatinine clearance ratio of less than 0.01, I would say to you that statistically, it's more likely that that patient has primary hyperparathyroidism than FHH. Parathyroid hormone is a calcium conserving hormone. What's filtered at the glomerulus gets held onto. PTH holds on to calcium. And for a given amount of calcium in the circulation, under the influence of PTH, the urinary calcium will be lower. So even in a situation where the urinary calcium seems to be low and compatible with FHH, statistically, epidemiologically, it's not. Now, you will see FHH. It exists. But often there's a family history. Often this disease penetrates very powerfully. So by the age of 30, the disease is manifested. These patients typically have had unsuccessful neck surgery for presumptive primary hyperparathyroidism. I think the most common reason for the low urinary calcium in people with parathyroid hormone-dependent hypercalcemia is diet. 95% of my patients who come to me with hyperpara are on a no calcium diet because their local doctor said, your calcium's up, watch out, don't drink milk, don't eat cheese, don't eat yogurt. And they're on a low calcium diet. And so that plus the hyperpara, so the first thing you ask is, if you happen to have a patient who brings in a urinary calcium that you haven't ordered, you have to know what the patient was eating during that day. And if you're going to order a urinary calcium, a 24-hour urinary calcium, which you should do, make sure the patient's on a regular diet with a reasonable amount of calcium, like 800 to 1,000. Or if you don't, then you're going to get confused between FHH and hyperpara. I know I'm giving the wrong story, but it's not the wrong story. It's the right story. But don't be fooled by urinary calcium in hypercalcemic situations. On the other hand, it's a real disease. FHH is a real disease. In the adult, the heterozygote form presents as hyperparathyroidism, and of course in children, it's a life-threatening. When it's homozygous, it's a neonatal severe hyperpara is truly life-threatening. So we do know that this disease exists, and we know that it's due to many, many inactivating mutations. I don't know how many have been described that all are functional, that is, rendering the calcium receptor dysfunctional.
One question.
Yeah.
So I've always been curious why FHH can have mild hypercalcemia and no manifestations, and we are just okay and permissive with this calcium level. Can we just be missing maybe some consequences from this calcium, or that we don't know, or?
You mean why is it that they don't get into trouble?
Yeah.
Hunter Heath called it familial benign. He actually used the term benign hypercalcemia to make the point, but not to explain it, that these people unusually have trouble, unusually. There have been kidney stones that have been reported, but generally they do well. I don't know why. I can't. But certainly the clinical message is if you make the diagnosis of FHH, you aren't going to operate on these people. And you can make the clinical diagnosis easily because you're going to suspect it. You're going to be, 25-year-old with a family history of hypercalcemia. Yeah, you're going to go after it, and you'll do the gene. You can do the genetics easily. Just draw the blood and get the sample and get the gene sequenced. So I'm not saying you shouldn't do that if you suspect it, but I don't know why these people, why their natural history is so benign. I don't know. Don't think anybody understands. Because they have hyperpara. I mean, they do. They have a high PTH, and they have a high calcium, and the biochemistries are not that different. The PTHs tend to be a little less, maybe subtly, a little, not quite as high as a typical hyperpara, but you'd have to have a big population to make that point.
And I thought in FHH that their serum calciums aren't that high. Like they're maybe sitting at 11, 11.5, but if you start seeing like 12s and 13s, then you have to reassess the patient too. So they don't really go that high, and that's what we were taught, that's why they don't get into trouble, because they're never that high to begin with.
Right. Well, that is true. That is true. Their hypercalcemia tends to be mild. Very true. There have been a few cases where that isn't true, but in general, you're right. But are you going to tell me that it's the average serum calcium is not as high as the average patient with hyperpara these days? What's the average calcium in hyperpara? About 10.8. So you're right. In the old days, when we saw hyperpara showing up with higher calciums, you could make that distinction. But now, the natural history of hyperpara, or the presenting history of hyperpara, in our study, the average calcium is 10.6.
But no, the reason why they don't run into trouble, the FHH population, is because they just don't rise that high, is what I was saying.
Yeah,
if you leave a hyperparathyroid patient alone for years, wouldn't you assume that their serum calcium would just continue to rise, and that's why they get into trouble?
It doesn't. I don't know if Shawnee's going to show you our 15-year data, but we have 15 years of follow of primary hyperpara. And out to year 13, the serum calcium was rock stable at 10.8. It is true, between years 13 and 15, the calcium inched up to 11. It did inch up a little bit. And they did have progression of disease in terms of kidney stones, fractures, and reduction in bone density. So there is a natural history of primary hyperpara, particularly after the first decade, that is progressive. But for the first decade in mild asymptomatic hyperpara, very hard-pressed to show that there's evidence for progression. So in a sense, it's not that different from FHH.
Maybe it is a genetic disease and the body just believes that it's normal. You was born with this PTH.
Yeah, the body has always known it to be. Yeah, it's a good thought. The body has not known it to be anything different. And maybe that's, for the body, for the person with FHH, it's normal. Yeah, maybe. Although it doesn't, but the body hasn't become hypercalcemic until, 30 years old or so. So the person who harbors the gene, it typically doesn't get expressed until a certain. But you're right. There's a genetic basis for it, and maybe that's why they don't appear to behave as if there's something wrong.
A question. Is there any role of cinacalcet in FHH?
I don't think so. I don't know of any studies that have looked at cinacalcet. I can't imagine that they would want to use cinacalcet in FHH. In hyperpara, we reserve cinacalcet only for people whose hypercalcemia is not mild, that is more than 1 mg/% above normal, and who are not candidates for surgery for one reason or another. Those are the situations where we would use cinacalcet in primary hyperpara. But in FHH, no, I don't, and I don't know of any experience that has used cinacalcet. Going back to the point that the calciums are typically not that high. So in the FHH, you have reduced sensitivity to the receptors. So the same kind of relationship. Here the normal is in the red, and these people require a higher serum calcium to control the parathyroid gland. It's just a different set point. The activating mutations have a sensitive, more sensitive set point. These people have a less sensitive set point. And again, the mutations are many. When you go for genetic analysis, the labs will, if there is a gene, there's a mutation, they will scan the data bank that they know about. And they will tell you there's a mutation in the calcium receptor that has been previously described in FHH. You can have a mutation in the calcium receptor, and it can be a perfectly normal receptor. It's not a functional abnormality. So that's why just because a person has a mutation in the calcium receptor, you have to match it up to a known mutation that has been shown to have a dysfunctional receptor. Or you could go to the trouble of an in vitro system and show that that mutation is abnormal. So it can be very misleading. And even more complicated, there are people with primary hyperparathyroidism who have been described with FHH. So, you know, it gets to be really complicated sometimes. But these are 1 in a million people. It has been described, though. All right. So ionized calcium, very important for the control of the parathyroid. And the other very important hormone that controls the parathyroid is 1,25-dihydroxyvitamin D. And it'll never be called a hormone. It'll always be called 1,25-dihydroxyvitamin D. So what does parathyroid hormone do? It's very important in maintaining normal bone remodeling. Obviously, it controls the serum calcium. I didn't mention the phosphate, but I should. Parathyroid hormone is a classic phosphaturic hormone. And that is why, in the old days, in hyperparathyroidism, the serum phosphorus is low, below 2.5. These days, it's very unusual to have frank hypophosphatemia in primary hyperpara. Typically, the serum phosphorus is 3 milligrams per deciliter, lower limit of normal. But you would expect someone to have very active hyperpara if they have frank hypophosphatemia. And very interestingly, these two hormones control each other. And so parathyroid hormone activates the 1-alpha hydroxylase in the kidney to help convert 25-hydroxyvitamin D to 1,25-dihydroxyvitamin D. Okay, and then the net effect, of course, is to bring the calcium up, presumably because there's been a hypocalcemic stimulus. Parathyroid hormone will resorb calcium from bone. It'll reclaim calcium from the kidney. It doesn't do very much to the GI tract directly. It does stimulate 125, and then 1,25-dihydroxy will help absorb calcium from the GI tract. But PTH doesn't have any direct effect on the gastrointestinal tract. Okay, so we'll now talk about 1,25-dihydroxy, which is the second of a lot of regulating hormones. We don't have time to cover everything. But this is the famous sequence that we all know about. The sequence of activation of vitamin D, whether it's vitamin D2 or vitamin D3, but in the humans, vitamin D3, unless you take a supplement, it gets hydroxylated at the 25 position in the liver, and then gets dihydroxylated at the 1 position in the kidney to form active vitamin D, 1,25-dihydroxy. Very interesting points about this sequence. First of all, it was first discovered like in the mid to late 1960s And all of you don't have a memory of that time, but I do. And it's amazing. We didn't know anything about vitamin D. People thought that was vitamin D. But Hector De Luca was the man who elucidated this pathway. Michael Hollick was a MD PhD student at Madison when Hector was there. Have you interacted with Hector?
I have, yeah.
He's amazing, isn't he? Hector is, I can tell the world, because he won't mind. Hector must be 85, 86. And the guy still has a very active lab. And last June, we invited him to Pisa at the Vitamin D Controversies workshop. And Hector was great. He was sitting in the front row. Every single presentation, he was sitting in the front row and making really erudite comments. It's amazing that he is just so productive, like we say, even now. But even then, and then when Michael Hollick was an MD PhD student at Madison, but they elucidated this pathway. And everybody, this is it. This is the truth. There is no further active metabolite. You say, well, what is the next arrow? There is no next arrow. 125 is it. There are arrows that go from 25 to 24-25 dihydroxyvitamin D in the liver, a very important inactivating pathway. And then there are trihydroxylated metabolites. In fact, Hector shows a slide. He's a unbelievable chemist of all the formulations of this corticosteroid. It's amazing. But in terms of our needs, we know about these two. 25-hydroxy is minimally active and only under conditions of toxicity do you see the pharmacological actions of 25-hydroxy. So what would that situation be? Well, patients getting vitamin D, toxic amounts of vitamin D, that happens. There's a homeopath from the DR, Carmen, you know what this homeopath is? It's called
Moringa?
Solidec. I don't know what the Spanish is, but Solidec. It's called Solidec. And you can buy it on the streets of Washington Heights directly from Santo Domingo. And it is a clear, colorless 5 cc vial. And it says Solidec, and it's for your aches and pains. And you take a swig, and 5 cc's, take it, and it costs only $5. And you take another one, you take another one. We had an epidemic of vitamin D toxicity. 25-hydroxy levels were all over 200 nanograms per ml. 125-dihydroxy levels were minimally elevated, like 65, 70 picograms per ml. But it was the 25-hydroxy that had piled up based on this material. When we assayed it, in fact, Neil Binkley and Hector, they assayed it for us. In the 5 cc's, it said on the bottle, 500,000 units of vitamin D. But when we assayed it in Hector's lab, it was 883,000 units of vitamin D. And people were just swinging it down until they felt better or felt bad. It's a great example. First of all, you should remember this when you have somebody with unexplained hypercalcemia due to vitamin D toxicity with a 25 that's very high. The first question we ask here is, are you taking something? And they say, no, doctor, no, doctor. Bring your bag in. Let us see what you're taking. And you might find Solidec. Anyway, so that makes another point. And that is, the liver will convert 25-hydroxy almost quantitatively. And it doesn't have controls. That's why it's 25-hydroxy that's the culprit. It gets converted to 25. And as much as the liver sees vitamin D, it's going to make 25D. On the other hand, again, Tom Nicholas would say, smart kidney. The kidney won't allow one to form unlimited amounts of 125-dihydroxy because the calcium regulates it. The phosphorus will go up in vitamin D toxicity. That regulates it. The PTH will be suppressed by virtue of the hypercalcemia, and PTH regulates it, but when it's low, it's impaired. And 125 itself regulates itself. So when it makes 125, it will feed back onto this enzyme. So it's extremely difficult to become vitamin D toxic due to 125 dihydroxy, or unless you're taking too much. So if you're in Europe and take 1-alpha, but in Italy you take both. You have both, right? 1-alpha and calcitriol. But in many parts of Europe they use a 1-alpha analog of D that then becomes active 125. But you can become toxic with 125 by taking too much calcitriol. And we'll see that in people with hypopara who need a lot of vitamin D. But this is very important for you to understand what this pathway means in terms of the pathway itself, activation, and clinical syndromes that can be associated with hypercalcemia. It is often, a question about vitamin D toxicity often appears on the boards. I was on the board of endocrinology and metabolism a few years ago, 1990 to 1996, I believe. And there were questions about vitamin D toxicity, but I swore I didn't write them. Nobody knows who writes these questions. Actually, we all write these questions. One of us is assigned to a question, and we write it, and then we spend hours, believe it or not, on each of the questions. Not to trick you. We're not trying to trick you, but we're trying to make the question perfect. The stem has to be written just right, and we have to have the right distractors. The wrong answers we work on just as much as the right answers. All right.
Well, sorry. So how did you treat that patient?
Oh, well, yeah. What we do, we use, of course, the usual treatment for hypercalcemia, which we're going to talk about, because this is actually a bone-resorbing state. Vitamin D toxicity is not only impaired excessive calcium absorption. These people are not excessively absorbing calcium because they're sick, they have nausea, they're vomiting, they're not taking in fluid. Excessive vitamin D resorbs bone. So you will use anti-resorptives. So we'll use fluids, hydration. We're going to talk about the anti-resorptives. You'll treat them just the way you treat anybody else who has symptomatic hypercalcemia. The fact that you may know that the patient has vitamin D toxicity might lead you to use steroids, because steroids are extremely effective in any kind of vitamin D toxicity. All right. So the 25-hydroxyvitamin D is the storage form of vitamin D. If you start with vitamin D itself, it is extremely lipophilic. It likes fat. You put a hydroxyl group on it, and it is less lipophilic, but it still very nicely gets absorbed into fat. And you put another hydroxyl group on it, and it is much less hydrophilic. So that explains why the half-life of 25-hydroxy is about 2 to 3 weeks, while the half-life of 125-dihydroxy is about 6 hours. So you're not going to measure 125 to get a sense of body stores because it's such an evanescent moiety. Very similar to T3. You're not going to measure T3 to get a sense of thyroid stores because T3's half-life is 1.7 days. You're going to measure TSH, actually. But we don't have a TSH in our field. But you're going to measure 25-hydroxy because that is the form of D that gets into fat and will be accessed over time. People who are very fat will have a lot of vitamin D in their fat. And their circulating D, just as a function of body size, their circulating D tends to be lower, despite the fact that they have a lot of more D than you would expect. And it's not clear whether the partition between fat and lean tissue and the circulation is altered in obesity. But obese subjects do have a lot of vitamin D stored in their fat tissue. Okay. Any of you measure, oh, by the way, Dr. what's his name? Lynn from Georgetown. Do you know him? Kenneth Lynn. Says Georgetown. He I think I have a, I'll tell you about him. You don't know him? Okay. All right. I'm going to hold that thought. So what does 125 do? Of course, it helps to absorb calcium and phosphate from the GI tract. Like PTH, it helps to stimulate bone remodeling. And as I mentioned before, it feeds back and regulates parathyroid hormone. And the net effect of 125 is, again, to bring calcium from bone into the circulation. Well, you're going to say, well, what about rickets? You need vitamin D to form bone. Yes, you do. But when we look at vitamin D as a regulator, it really does resorb calcium from bone, and it facilitates calcium absorption. So in a different way from PTH, it stimulates, improves in circulating calcium. Kenneth Lynn, look him up. And look at this reference, April 30th, 2018. That's yesterday. Is that right? Wasn't April 30th yesterday? I'm really up to date. And this was in Medscape. And Dr. Kenneth Lynn says that we're measuring much too much vitamin D. Nobody needs supplements. This is all a charade. So I wrote to him yesterday. He hasn't written me back. I wrote to him and I said, Dr. Lynn, I don't know you and you don't know me, but I think your statements were a little bit over the top. He's not there? He's not there?
He's here, but I actually think he's part of Innova Health System, which is very close by to us.
Ah.
And maybe his credentials say Georgetown. Maybe he was at Georgetown at some point.
Yeah, yeah.
But he's actually at Innova Health, which is very close by.
So you disclaimed him.
No, I just don't know him.
Yeah. Well, I don't know this guy either, but it's one of these sort of, these people just are, they're wrong. They're wrong. Can I tell you? They're wrong. They're wrong. They say there's no vitamin D deficiency in the country. We're measuring too much vitamin D. Nobody needs supplements. That's what the statement, that's what he says. And so I'm going to call him on that. My premise is that vitamin D deficiency is common. Now, this is from my colleague's work showing that, is there latitude dependence of vitamin D deficiency in the United States? Not really. It's hard to show that the northern latitudes have more than the southern latitudes in this country. If you go way up, like in Canada, maybe, or Northern Europe, there might be something. And there might be some latitude dependence. But in the US, it's hard to demonstrate. So why, if we have vitamin D deficiency, if you allow me for the moment to say we do, how common is it? And why? Why do we have vitamin D deficiency? We certainly have the sun. And the sun is our source of vitamin D. It irradiates at a certain energy of 90 to 110 nanometers of energy from the sun, which you get in this part of the world between now, that is end of April, to October. So the sun now is come north and is hitting the earth at an angle that has that energy. So our skin will convert 7-dehydrocholesterol to pre-vitamin D through that energy. And then the skin will then, it'll be picked up by vitamin D binding protein, and then the metabolism will occur. Between October and April, at 42 degrees latitude, there is no sun energy hitting the earth. Now, where is the sun? It's in Brazil. It's in Argentina. It's in Colombia. And so they're getting the energy, but we're not. And then the further north you go, the less time you have, that is, of the year, the fewer the months are where that sun is going to give you D. So the sun is seasonal in terms of its supplying us with the right energy of vitamin D. Yes, maybe it is. I think extreme latitudes. Now, the dermatologists, of course, are rightfully concerned about skin cancer, melanoma, skin health, and they're right. They're right. more sun exposure can be very bad for our skin. And regular recommendations are to stay away from the full sun, use sunblock, and the sunblocks that we use will completely prevent that wavelength from getting to our skin. So that even when we're out in the sun in the summer, we aren't getting vitamin D. So there are cultural issues here, particularly in the Middle East, where women are still, in some countries, fully clothed with wearing an abaya. And I'm not totally sure, by the way, that that's the reason, because there was a very interesting study from Saudi Arabia that looked at women who were completely clothed, that is, with just the eye slit, women who were clothed but their headscarf exposed their face, and women who were wearing Western clothes with a headscarf. And this was done just a couple of years ago when I was in Saudi Arabia, and they presented this very interesting paper. And they measured 25-hydroxy levels among these three women, groups of women, and the levels were the same. Exactly, all low, but they're exactly the same. So I'm not sure. I think there's a genetic thing here. I think there's some protection by virtue of so many thousands of years of living in the desert. Maybe the skin has developed a certain resistance. I'm not sure what it is. But cultural, maybe. Environmental. Last time any of you was in Beijing, China, you will not see the sun, even when the sun is shining, because of pollution. It's true, some parts of the world beyond that. Sao Paulo is awful in that regard. So when the environment is polluted, again, the wavelengths don't come through. And the dermatologists tell us what to do. So now I have to have you impressed, please be impressed, by this animated, the sun has been eclipsed.
Wow.
That's my eclipse of the sun as a source of vitamin D. Yeah, if you're lucky, you're going to get D from the sun, but generally not the sun. So, okay, if we don't get our vitamin D from sunlight, I'm sorry, what's happening? What about food? Should get vitamin D from supplement foods and stuff. Well, natural foods, like corn products will have D, and certain fishes will have D, like salmon. Cod liver oil, you know why we talk about 400 units of vitamin D? Because when in UK in the 1930s, when it was discovered that a teaspoon of cod liver oil cured rickets, that's true. A teaspoon of cod liver oil cures rickets. And somebody, I don't know how this happened, but it was decided that that teaspoon contained 400 units. So if you can cure rickets with a teaspoon of cod liver oil, that must be what we should all be on. So up until 8 years ago, the requirement, the nutritional recommendation was 400 units of vitamin D. Well, salmon gives you some. Mackerel's interesting fish, very oily fish, gives you some. Fortified milk. A lot of countries don't fortify milk. You don't have D in Italy with milk. We may be the only. In Canada, do you have D in milk?
Yeah.
You do? Yeah. There are many countries that don't have fortified their dairy with milk. And in fact, up until recently in this country, only milk was fortified. There are now some yogurts. There are some yogurts that will be fortified. But up until a few years ago, yogurt was not fortified with D. Anyway, so there is D in food, but the average intake, and this was from N. Haynes 3, among men of many ages and women as well, was well under even the minimal. In fact, we now think we should all be taking more than 400, but from this study, the average intake was about 300. So it wasn't even in terms of diet, people were not getting enough D. So if we're not getting D from the sun, and we're not getting D from our foods, ergo, we are probably all vitamin D deficient. This is from Neil Binkley. And Neil showed that in his survey, 71% of the 71 women, 59% had levels of 25-hydroxyvitamin D that were under 30 nanograms per ml. And we won't argue yet about what's the right number. But his study showed he had picked 30, and 60% of these women had levels that he thought were in the deficient range. Bob Heaney has looked at this. I believe this was one of Bob Heaney's papers. And he looked at women who were getting adequate D versus those who weren't. No, he was showing that 70% of the women in this age group and 90% of the women over 70 were not getting adequate D based upon what they were thought to get. So this large population survey from Haynes sort of supplemented what I just said. Everybody was seemingly vitamin D deficient. So this paper by Paul Lips was an international survey, convenient sample of 2,500 postmenopausal women, 18 countries, and spanning the latitudes of life, 38 degrees to 64, so very wide latitude. And again, like Neil showed, 64% of this world population had 25-hydroxy levels less than 30 nanograms per ml. And this goes from region to region, and it goes as high as 81% in the Middle East there. That's why I think there's something about the Middle East that's different, and it isn't the clothing. Anyway, 81%, but it doesn't matter what part of the world. There was a lot of vitamin D deficiency globally. All right, so now we come to the controversy. What is normal? And before I tell you what I think, so how many of you consider 30 nanograms per ml to be a level that you strive for in your patients to define adequacy? Okay, most of you, majority of you. How many of you subscribe to 20 nanograms per ml? Okay. You 20? I didn't know that. Different. That's a different discussion. I got you. Okay. And how many are 10? Yeah, 10 seems okay. Well, okay. So most of you are 30. You are 20. So another question: how do we determine what's normal? It's an important question. You could do the laboratory reference range, but you better be sure that your laboratory is representing the normal population. And I don't know what's a normal population. If you take the next 200 people who come into the hospital off the street, are they normal? No. They come to the hospital for a reason. You know, if you take 100 of your colleagues, are you normal? No, you're not normal. There's something wrong with all of us. I don't know what's normal. How do you get a normal population? That's the difficult question. How about regulatory index? How about a relationship of vitamin D to something else? And where do you get sufficiency? And this paper is really an old paper, but it really is just a beautiful paper that tracked. The design of this paper was not to look at this relationship. The design of this paper was to know what the prevalence of vitamin D deficiency was in a population of men in Boston who had been admitted to the emergency or come into the emergency room with crushing chest pain. They were having a heart attack. And in the course of their evaluation for the heart attack, a sample was drawn for vitamin D. Okay? So these were free-living subjects who suddenly were ill, were in the emergency room, and in the course of their workup, blood was drawn for vitamin D. This came out of this study. It was not the idea. And it tracked, now granted this is cross-sectional, I understand, but they tracked the level of 25-hydroxy against the parathyroid hormone level in these subjects. And you can begin to wonder whether the inflection point begins here, or maybe you don't like that. Maybe you think it's here. And certainly below 20, it's clear that under 20, the PTH is clearly going up. The big controversy is between 20 and 30, is the system tuned to register a need for more vitamin D, PTH, based upon the 25-hydroxy level. And we are not sure. There's another way you could look at it. Besides a regulatory index, you could look for a physiological index. That is, if you optimize calcium absorption, can you affect vitamin D? And this was a Bob Heaney paper. He gave a group of subjects with vitamin D supplementation to get their levels to 35, and a group that was not supplemented, and their level was 20. And then he determined calcium absorption after that same calcium supplement dose that we talked about. And those who were replete, that is, had a level of 35, had 60% higher calcium absorption than those whose level was 20. And this is the example. Those who had gotten the supplement had a lower fasting PTH by 17% and a greater percentage of calcium absorption of 65%. So there is some regulatory data. By the way, nobody has really done a good study to take a group of subjects whose level is 20 nanograms per ml, give them calcium supplement, vitamin D supplements to go up to 30, track individually, longitudinally, and show within that range in a given group of subjects, you are modulating PTH. That would be nice to be able to show that, but nobody has yet. Again, Bob Heaney showed that this threshold nutrient is vitamin D. When you get up to 50, was it 50 nanomoles? No, 70, I'm sorry, where is this? 70 nanomoles per liter, somewhere around 70 nanomoles per liter. I guess he put it at 32 nanograms per ml, so it's probably 75, 80 nanomoles per liter. You reach the threshold of calcium absorption, and any further increase in vitamin D did not further increase calcium absorption. So the thinking was that the threshold value was around 30, 32 nanograms per ml, not 20. So the thinking is that some people feel that it should be around 30, 32 nanograms per ml, or 80 nanomoles per liter. But the Institute of Medicine disagrees. The Institute of Medicine says, this is from 2010, there's no convincing evidence that PTH levels rise consistently when the 25-hydroxy levels fall below 30. And that's true. It's not, what I showed you is not always demonstrable. They did not like Bob Heaney's data. They said there's no convincing evidence that optimal calcium balance requires a 25 level greater than 30. They picked apart Bob Heaney's paper. They did take it apart. And nothing's perfect. They did find a few issues that were that could be called into question. There's no convincing evidence that skeletal health requires levels greater than 30. And there's no convincing evidence that putative non-skeletal effects of vitamin D are, one, substantiated, and two, associated with 25 levels greater than 30. So they then proposed, and this is for the healthy population. This is the thing that did not get emphasized in that report. They're talking about a healthy population. They're not talking about a population with osteoporosis. And we can argue about the normal population, which is what we're arguing about. But I don't think we should be arguing about an osteoporotic population. You don't want to cut the margin that low. Again, they were impressed that when you got below 20, that's when you saw these issues related to vitamin D deficiency. So the Institute of Medicine says that under the age of 70, that is all of you, should be taking 600 or getting in 600 units per day, up from 400. This is the first time the nutrient recommendation has been changed in 30 years or more. And 80 units for your patients over the age of 70, with a maximal daily intake of 4,000 units per day. Whether you do it daily, some of you might like to use weekly D in your patients. 10,000 units of vitamin D would be equivalent to 1,500 units. Most of us have gotten away from using 50,000 units once a month. First of all, vitamin D doesn't last for a month, so the last week of the month you're going to not have a vitamin D effect. We're shying away from high doses of D for other reasons having to do with fracture risk and falls. Not so much at 50,000, although it's getting to, but bolus D of 100,000, 300,000, we don't use anymore because of issues. And the Institute of Medicine says we should aim for levels between 20 nanograms and 50 nanograms per ml. So this is what they're saying. Take this arrow and move it to 50 nanomoles per liter or 20 nanograms per ml. Now, let me, this is still controversial. And Mike Hollick and Bob Heaney several years ago wrote about this. And the groups, some of the groups, the Endocrine Society continues to keep their 30. So my view is in our osteoporotic population, I think we're advised to go for 30. And I think there's a lot of upside safety to vitamin D, certainly up to 50 nanograms per ml. And I see no reason why we shouldn't go for 30. And I'll give you a few more reasons why. Given that, and this is, Neil Binkley's been talking about this forever, the assays are really problematical. There may be up to 20, 30, 50% variability in these assays. So to ensure a level of 20 nanograms per ml, actually the measurement should be closer to 30 because the measurement might be wrong. If you want to get to 30 nanograms per ml, maybe you should aim for 40. Again, given the fact that we don't know the assay itself is telling us what the truth is. And another point, if the population norm is aimed for 20, that's what the IOM says, okay? 20. If you aim for 20, then half the population is going to be below 20. If the average level of the population is 20, half is up and half is down. So if you go for 20, half of the population is going to be deficient. If you go for 30, half of the population will be under 30, but that's better than under 20. Nobody wants to be under 20, and some of you can live with under 30. So I'm on the 30 nanogram per ml view from a population point of view, and I'm also at the 30 nanogram per ml threshold for our patients with metabolic bone disease, because I think that you're going to give yourself a measure of tolerance here, and you're not hurting. You're not doing any harm. So if you're not doing any harm and you might be doing good, you should try to do the good. So give me your argument for 20.
We are trained based on the Institute of Medicine, so this is on human, like healthy human subjects.
Yeah.
If they have mineral disease, then there is even like studies that says like for SLE, patients should go up to 100, no more than 100, because decrease the frequency of flares. But we follow the Institute of Medicine.
Okay.
At the end, so we say the PTH only changed between 20 to 30, like by 2 points, like 2 PJ per ml. So we say what is the difference between 20 to 30?
Yeah.
So if they come in that range, we recommend them to eat it in diet. But we don't put a lot of pushback for them to buy the vitamin D. But if they come below 20, then we tell them, and it's based on this PTH change.
Well, read Dr. Lin. Did any of you get Netscape? Did you get Netscape? Well, this was from yesterday. Read him. I like your idea better. He's out. He's a little bit off in right field, if we use a baseball analogy.
So, you said you don't use the 50,000 units?
Not anymore.
Because what I've been told was you'd maybe do 50,000 a week for 1 or 2 months and then switch to...
Oh, yeah. Well, I don't do that anymore, but we used to do that. So someone who's very D deficient, yeah. Yeah, you could do it. You get the D up more quickly.
So it's okay just to do 1,000?
Yeah, well, I would do more. No, if somebody is really D deficient, I would put them on, so here's a rule of thumb. For every 1,000 units of vitamin D that you add to somebody's regimen, do you know at the next steady state, which will be 2 months from then, how much higher will the 25-hydroxy vitamin D level be in nanograms per ml? It'll be up, for every 1,000 you add, the new steady state level will be higher by 10 nanograms per ml. So if you want to go from 20 to 30, you want to add 1,000 units per day, and it'll take 2 months to get to 30. If you're at 10 nanograms per ml, and you want to get to 30, you'll start 2,000 units per day. But it takes time. So your point, Emery, is that get it up quickly. Why wait 2 months? And there's some wisdom in that. And depending on how low the D is, you might do that. So you just triggered a story I have to tell you. This was about many years ago. And I was asked to see a patient. She was in her late 80s. And she was living in Washington Heights, living alone. And she basically ate toast and drank tea and never went out. And she came to see me and she said, every bone in my body hurts, doctor. And so fine, I got that history. And I then said to her, you're retired? Yes, you're retired. What did you do? I think with HIPAA, I think I can tell this story. She said, I was a puppeteer. I said, you were a puppeteer? For what show? And she said, the Howdy Doody Show. Now, none of you have heard of the Howdy Doody Show. I can't believe it. You're all so young. The Howdy Doody Show I grew up with. This was the great puppet show of the 1950s. And Howdy Doody was the character. And there was Buffalo Bob Smith, and there was Princess Summer, Fall, Winter, Spring. And there was a character, there was Phineas T. Bluster, and there was a character called Flubadub. So I said, you were a Howdy Doody Show. What string were you pulling? And she said, I was Flubadub. So I said, you were Flubadub? I can't believe I'm sitting next to Flubadub. What's going on? She says, doctor, enough of the Flubadub. I'm hurting. You have to help me. I'm hurting. So I said to her, I know what's wrong with you. I want you to take vitamin D. And this was before I got the acid. I didn't get the level until later. But I was convinced she was severely vitamin D deficient. And so I said, I want you to take vitamin D. And I want you to take a lot of vitamin D. I want you to take 50,000 units of vitamin D every day for the next 10 days. She looked at me and she said, doctor, you're going to kill Flubadub. What a great statement it was. Anyway, she took the 50,000, and I said, I want you to call me in 2 days, because I said, you're going to start to feel better in 2 days. She calls me in 2 days, and she says, I feel so much better. Now, I got her vitamin D up very quickly. Within a few weeks, I had gotten her vitamin D up. By the way, when I got it measured, 0, undetectable. Do you know what her PTH was? I still remember the number, 962. Unbelievable. The other thing that case taught me, well, taught me a lot, as you can tell, never forgotten it. Do you know how long it took me to control her parathyroid? The vitamin D came up very quickly, within a few weeks. It took me 2 years before I could control the severe secondary hyperpara. And I did get her PTH to normal. That is a fabulous example of how it can take a lot of time to control the secondary hyperpara, particularly in renal failure. I don't know if Tom talked about this, but the hyperpara after renal transplant can be a really long, drawn-out affair because it takes so much time to control the secondary hyperpara, even after the transplant has worked. But that case was a good example. And so I think you're right. You can use 50,000 if you're dealing with very low levels. But for the levels we typically deal with, 15, 20, 25, I just start them on a dose that will be good, will be maintenance, and they'll get up there.
So you say every 1,000 international units of vitamin D raises vitamin D by 10 points?
10 points.
Per day?
No. No, 10 points by the time you're at steady state. No. If you're starting at 20 nanograms per ml, and you want your patient at 30 nanograms per ml, if you start 1,000 units per day, 2 months later, after 1,000 units a day for 2 months, they will take that long to get to the new level, because it takes time, and that new level will be 30.
In 2 months. Period.
Yeah, it takes 2 months, 6 weeks to 8 weeks. Yeah, but the rule, so if you want to go up to 40, you have to use 2,000 units per day for the long. Now, it's not going to keep going up. The new steady state will be 30 or 40, and then you can keep that maintenance. Yeah, okay? No, it's a nice rule of thumb, and it works. I actually track it myself when I start a patient on a certain amount of D. I know what the number is, and it actually, I had one patient, she thinks I'm a genius. She was at 26, and I wanted her to be over 30. I said, I want you to take 1,000 units a day, and 2 months later we're going to check your D, and it's going to be 36. And so she came back and it was 36. She said, Doctor, you're so smart. It's purely luck.
Can I ask something else? Sorry. So if you gave very high doses of vitamin D to get to 1 point, and now you want maintenance, do you still need to give those high doses then to keep it like?
Not if you're using 50,000, no, that's for sure. But the question is, do you have to adjust after you've gotten to your next dose? So you've given 2,000 a day, and you've gone from 10 nanograms to 30. And the question you're asking is, do you have to stay at 2,000, or do you have to? And I don't know. There are people who you do have to cut back. There are for sure. And there are others who just seem to need more vitamin D than you would think. I mean, 2,000 units a day is more than anybody recommends. And yet I have a lot of patients who need 2,000 units a day. I can't answer the question. You just have to check, and you have to track it. Yeah, there's no, I would say about half my patients I have to adjust after I get them to the new level. And the other half, no, they're fine. So, vitamin D is very well tolerated. Comes in capsules. In your patients who are Orthodox in the Jewish religion, you can buy kosher vitamin D from Frida Vitamins. So you can get kosher vitamin D. Vitamin D can be taken anytime, day, night, with food, without food, and it is really well tolerated. I have one patient who tells me that she gets diarrhea every time she takes the capsule. I don't know. But it's very unusual that patients have trouble with vitamin D. And this is just, we've just gone over, if the calcium is low, you're going to immediately stimulate PTH, which is going to stimulate 125, which is going to help rectify the hypocalcemia by bringing in calcium from the GI tract. It'll bring in phosphate, but the high PTH will get rid of the phosphate, conserve your calcium, and the net effect by working together, PTH and 125, will be to restore that hypocalcemic signal. That's the homeostasis that the body deals with. We talked about this, and again, if you can measure ionized calcium and believe it, go for it. But most of us use the total calcium. We aren't going to talk, at least at this time, about the other regulators. FGF23 is becoming a big player. It also, did Tom talk about FGF23 and how it regulates PTH? It is important. The gonadal steroids we're going to touch on, of course, glucocorticoids, thyroid hormone, growth hormone. These are all things we're going to cover throughout the next 2 weeks. And then the local regulators we're going to touch on as well. The big pathways, Wnt signaling, rank ligand, OPG, and products of the osteoclast are all important. This rank ligand system, I thought I would just mention briefly. Rank ligand is a product of the osteocyte, maybe the osteoblast too. But rank ligand is a very, very powerful cytokine. And it is a resorber, bone resorber. If the body had not evolved to control rank ligand production or to mitigate rank ligand production, we would all be jellyfish. Because it'll just destroy your bones. It'll dissolve your bones. And it does so by stimulating the mature osteoclast and also the development of the immature osteoclast, and thus causes bone resorption. And the examples, the experimental examples of too much rank ligand, if you knock out the decoy receptor, OPG, basically on the left you see no bone. If you get rid of rank ligand, or overcompensate, you get an osteosclerotic picture. So these mouse genetic studies really clearly show the importance of rank ligand, and rank ligand has been touted to be involved in lots of things. You name it, you can see some involvement. You name the disease, and rank ligand will be involved. I'm sorry, what happened? Okay. What we're going to do, oh my God, it's 11:30. Okay. What we're going to do is stop. And this afternoon, we will, I think we can do the hypercalcemia, hypocalcemia. We meeting at 3:30? What time? 3 o'clock. 3 o'clock. We may go a little bit beyond. We may go to 4:15 or so. But anyway, so any questions at all? Yeah.
You mentioned that you typically don't correct the total calcium when the albumin is greater than 4. What if it's less than 4, but still within the normal range? Like, I'll commonly do that, especially if the total calcium is borderline, and I want to see if their albumin of 3.8 or something, or 3.7 maybe ends up pushing it over the edge.
Yeah, you know, I don't tend to pay a lot of attention to the albumin until it gets to 3.5. Yeah. It's the assay. The problem is that 3.7, 3.8, it's close to 4. You know, it's there's the error of the measurement that I worry about. So I really don't tend to adjust upward with that kind of low, not low, but minimally below 4. But when you get to 3.5, then that's an adjustment of 0.4. So I would do that. But you don't necessarily want to fine tune it to that degree. Okay, very good.